Great. So maybe we will just jump right in because I know we're going to get a ton of questions and lots of interest. And so want to maximize the time that we do have today to go through our session. So welcome to each of you. My name is Julie Beckett. I'm with the Ottawa Hospital Foundation, and I have the privilege of being your host today for this session. So we're so thrilled and appreciative to each and every one of you for taking the time to join us today. Our panel of experts will be speaking about breast cancer care and research here at the Ottawa Hospital and the wonderful care provided at the Rose Ages Breast Health Center. We're honored that the Ages family and so many wonderful donors in our city joined together to give so generously to make the Rose Ages Breast Health Center a reality. So a little bit about the format for our session. To get started, I'll introduce each one of our experts, followed by a few questions that we already have to start our dialogue. I then look forward to sharing your questions later in the session with our wonderful panel and would encourage you to share those questions using the Q&A function just at the bottom of your screen. We're so grateful for your participation. However, I do have to caution you, due to timing, our experts may not be able to answer every question. So we'll do our very best to get as many questions as possible. And if your questions aren't answered today, we will try our best to respond to you privately to see how we can navigate the best response. And we thank you so much for your understanding. Also, if your question is about a personal medical experience, we apologize, but those are really best handled by your medical care team. But I assure you that we will do our very best to answer as many questions as possible in our limited time. I would also like to encourage you to access the resource page on the main platform on the left-hand side when you first logged into the event. We do have a great page with links and further information relating to this breakout session, which is very useful. So without further ado, I would like to thank each of our wonderful experts, and I have the pleasure of introducing each of them. So we have with us Dr. Erin Cadero. Dr. Cadero is a breast surgical oncologist here at the Ottawa Hospital. She is also the medical director of the Rose Ages Breast Health Center. She is assistant professor at the University of Ottawa and senior clinician investigator at the Ottawa Hospital Research Institute. Dr. Cadero is also an amateur triathlete and has completed multiple half marathons and a half Ironman. Where does she find the time? And just a few weekends ago, she ran the Ottawa Half Marathon virtually to raise money for Run for a Reason. Welcome, Dr. Cadero.
Thank you very much. It's a pleasure to be here today.
We also have Dr. Jean Seeley with us. Dr. Seeley is the head of breast imaging at the Ottawa Hospital. She is regional breast imaging lead for the Ontario Breast Screening Program in the Champlain region. She's professor of medicine in the Department of Radiology at the University of Ottawa, co-chair of the Canadian Association of Radiologists Breast Imaging Working Group, and sits on the executive board of the CAR Mammography Accreditation Program. She's a fellow of the Society of Breast Imaging and an editorial board member of the journal's Canadian Association of Radiology and Breast Imaging. She is also president of the Canadian Society of Breast Imaging. Dr. Seeley is an avid cyclist and loves to spend time outdoors. Welcome, Dr. Seeley.
Thank you very much. It's a real pleasure to be here.
And last, but certainly not least, we have Dr. Zinni Song. Dr. Song is a medical oncologist and chair of the melanoma disease site at the Ottawa Hospital Cancer Center, specializing in treating breast cancer and skin cancer. Her research interests include clinical trials of cancer therapeutics, cancer survivorship, and medical education. She is the author of numerous oncology-related abstracts and articles, as well as a dedicated speaker and educator. When not at work, Dr. Song enjoys hiking with her family, and Newfoundland is her favorite hiking spot. Welcome, Dr. Song.
Thank you for the lovely intro. It's my pleasure to be here.
Wonderful. Well, we are thrilled to have each of you, and we thank each of you for taking the time out of what we know are very busy schedules to be part of this important conversation this afternoon. So my first question is actually for Dr. Cadero. So Dr. Cadero, could you tell us a little bit about the Rose Ages Breast Health Center and what services it provides to patients?
Of course, I would be happy to. So we were very excited to move into the brand new Rose Ages Breast Health Center about a year and a half ago. Previously, we were at the Civic campus, and then through the generosity of donors and the foundation, we were finally able to open our new space at the general campus. The new space is over twice as large as the previous space that we had at the Civic campus, giving us much more space and open natural light to provide a much more healing environment for the patients. So at the Breast Health Center, we provide a number of different services. There is the diagnostic side, which Dr. Seeley will discuss further. And then on the clinical side, we have a multidisciplinary panel of experts who are all there to treat and meet the needs of breast health patients within the region. We have 2 family physicians who have expertise in high-risk breast conditions as well as benign breast conditions. And we have 8 surgeons who focus on breast health care. We also have 5 nurses who provide expertise to breast health patients, as well as a social worker who provides counseling services, as well as coping strategies, and facilitates support groups for those patients as well.
A wonderful overview, and I think we are so very fortunate to have the Rose Ages Breast Health Center right here in our community. And again, so thankful to our donors who made the center a reality. My next question is for Dr. Seeley. So Dr. Seeley, I know you're working on something very exciting, a new breast cancer screening trial known as TMIST. Can you share with us what you hope to learn from that study?
So the easiest way to pronounce that is TMIST. And it's a great study, international, funded by the NIH, the National Institute of Health in the US. And it's a study of over 165,000 women with centers in Canada. We've been the lead sites in the United States and even other countries like South America and Europe. So I am the principal investigator of this study in Ottawa. And we've been recruiting now for 5 years, and we're one of the top sites in all of the world for this site. We fortunately have been able to recruit over 2,000 women in Ottawa alone for this study, which is an excellent number. So this study is a randomized controlled trial, which means that you don't know which arm you will get into. And we're allocating women to either a regular screening mammogram, as most of us have from age 40 on, or to the 3D mammogram. And we're looking to see whether using a 3D, which we call the better mammogram, actually helps to improve detection of breast cancers at an earlier stage. We have a lot of evidence that is showing that it probably does detect smaller cancers. And also, we are looking to see if we reduce the number of advanced breast cancers, which means those that have, are we picking up more early stage, the ones that haven't spread to the lymph nodes or to the rest of the body, which we know are associated with poorer outcomes. So this is a very exciting study, and we should be finished our recruitment probably in the next 2 years, and then have the outcomes within the next 5 years after that. So I'm happy to answer more questions. Thank you very much.
Well, very exciting, Dr. Seeley. And we know that research is the answer to enhanced care. And so really great to hear very exciting projects taking place. My next question would be for Dr. Song. Can you talk to us a little bit about what immunotherapy is and if it's an option for breast cancer patients?
Okay, that's such a hot topic right now in breast cancer. So I think in general terms, when we talk about immunotherapy, this would be a group of treatment that's very different from the traditional chemotherapy that we talk about. So chemotherapy can cause direct DNA damage, but at the same time, it could also damage healthy tissues. Whereas immunotherapy does not impact on tumor directly, but it's to stimulate the host or the patient's immune system. And the immune system then will produce cells that looks for cancer cells or other things to clear the cancer cells away. This type of therapy has been proven and currently used in many subtypes of cancer. For breast cancer, however, I think we have so many effective therapies. So I would say immunotherapy for breast cancer, we're a latecomer. Right now, I would say broadly, if someone's interested in immunotherapy for breast cancer, for most of the patient, we would encourage participation on clinical trials. I think that's the best way for the management, as well as we're still learning about how immunotherapy impact on cancer. There has been some early data looking at triple negative breast cancer. So this is the type of cancer generally do have more aggressive behavior. We have limited options. So immunotherapy became a natural choice for investigation in this subgroup of patients. There are some data suggesting in patients with metastatic triple negative cancer, when you combine that with certain chemo, it may result in we call progression-free survival, meaning that may delay cancer from growing or progression. Some reports suggesting a small gain in survival, but I think the data is still somewhat early, and we're still waiting to figure out who really benefits, right? We actually have a marker called PD-L1. So looking at that marker, does the patient have a positive marker or a negative marker? So I think this is an area there's still a lot of research to be done. Another areas of immunotherapy will look at early breast setting as well. So in Ottawa, I'm actually the lead for several immunotherapy trials in triple negative breast cancer. We're waiting for some of the data to read out. And so certainly I'm quite excited to see what the data would show, and hopefully we can offer this to our general population of breast cancer patients.
That's wonderful. Wonderful, Dr. Song. Very exciting, providing lots of hope, and excited to see where things go in the future. I've gotten a couple of questions around the same line where people are asking, how do they participate in Dr. Seeley's imaging breast cancer detection program? And so in the resource tab, there's a link that you can click on with all of that information there. So great to see there's lots of interest, Dr. Seeley. We also have another question for Dr. Seeley. So I understand that women with dense breasts are at a greater risk of breast cancer, and that dense breasts make it harder for radiologists to spot cancer. What imaging do you recommend for these women?
Oh, thanks very much. That's a great question. So I think it's very important. It's very hard to believe, but having dense breast is actually a stronger risk factor than any other risk factor, except for genetic mutation. It's even stronger than a family history. And having dense breast tissue is very common. So women who have dense breast tissue have twice the likelihood of getting breast cancer than a woman with a non-dense breast tissue. So what is dense breast tissue? It's the amount of glandular tissue that is in the breast. And I'm often asked, can you feel that? And the answer is no. The only way you can identify dense breast tissue is on a mammogram. So we recommend having a mammogram at age 40, if only to identify what the dense breast, if there is anything there. Now, in terms of how to detect a breast cancer on a mammogram, we we detect about, on average, 85% of breast cancers with a mammogram. With our 3D study, we think we might increase that to maybe 90 or 95%. But the problem still exists that even with the best mammogram, a cancer shows up as white on a background of white glandular tissue. And so we sometimes, despite the best kind of mammogram, we don't identify the cancer on that background of dense breast tissue. So we increasingly turn to additional diagnostic tools, and we add MRI in many women with dense breast tissue. And I wanted to, give a real thanks to our donors, because it's thanks to our donors that we are able to put a brand new MRI on in our new breast health center on the 5th floor. And we are in the process right now of getting that ready to purchase and install. So it's really thanks to all the generous donations that we've made that possible. And what we are anticipating is that we'll be able to use this MRI for more women with dense breast tissue to help screen additional women who we aren't able to at this point in time.
That's wonderful. That's great. Thanks, Dr. Seeley. And we have a ton of questions coming in. So I'm doing my best to work my way through those. I guess while we're on the topic of screening, someone is asking specifically about lobular breast cancer and what is the best screening recommendation for that?
Okay, so we recommend as the base a screening mammogram for all women starting at age 40. And just so I can give a bit of a when do you start screening, we recommend starting at age 40. But if you have a first-degree relative, I mean, your mother or your sister who is diagnosed with breast cancer, we would start screening 10 years earlier than they were diagnosed at. So it could be as early as 30 years old, and that's fine, but we don't do anything earlier than 30. So we always start with a screening mammogram, and then we recommend every year or every 2 years, depending on the risk factors. If you have dense breast tissue, we do it every year, and there's other indications for that. If you have had a history of a lobular cancer, the lobular cancers are not as common as the regular cancers, and they are more difficult to detect on a mammogram. But the great hope is that our 3D mammogram, which is already being shown in other studies, actually picks up more lobular cancers. So we're hoping that that will help with the screening with the tomosynthesis. And we are doing extra screening in our breast cancer survivors who also have dense breast tissue with MRI or ultrasound, depending on certain factors. So for all women, we would always start with a screening or a surveillance mammogram, because that's what's been proven to reduce the mortality from breast cancer by up to 40%. So even if you've had a history of a cancer that was missed on a mammogram, we still recommend continuing with a mammogram, because any kind of new cancer can show up differently on a mammogram. And it's still been proven with excellent evidence to save lives from breast cancer.
Wonderful. Thank you, Dr. Seeley. My next question is for Dr. Cadero. So this one relates to lymphedema, but I think this question will probably capture that. So Dr. Cadero, as a breast cancer surgeon, you're often the first point of contact for newly diagnosed patients. Could you highlight the advances in surgical techniques available at the Ottawa Hospital and maybe include lymphedema in that as well?
Sure. Yeah. So, but there's two real things that I would like to highlight. So here at the Ottawa Hospital, we have 3 surgeons who have specific additional training in what's called oncoplastic breast surgery. So myself and 2 others perform these type of complex surgeries in certain patients who meet criteria, who have cancer. And it's a way of doing breast cancer surgery that really, of course, our primary outcome is always to cure the cancer, but we really place a high emphasis on the cosmetic effects and the cosmetic outcome of the surgery afterwards. The real goal, I always tell everybody, is I don't want you to remember this time in your life going forward. And so whatever I have to do to you, I don't want patients to have to look in the mirror and think about this horrible time in their life. So we want to do everything we can to cure your cancer, but leave you with hopefully a nicer looking breast afterwards if possible. So here at the Ottawa Hospital, we do provide that kind of specialty services. And then the other one that we're really excited about is we have a new program where one of the plastic surgeons is doing microsurgery with the goal of hopefully preventing lymphedema in the future. So for patients who are undergoing a resection of their lymph nodes underneath their arm, if they're at a high risk of developing lymphedema, then we can do our surgery in combination with the plastic surgery who does this microvascular anastomosis. And some studies have shown that it really significantly reduces the risk of lymphedema going forward. So we have about 30 patients already recruited in that study, and we're really excited about the results and happy to see what is coming forward.
That's wonderful, Dr. Cordero. And is that something that you would commonly see in other hospitals, or is that fairly specialized?
No, so we are the only center in Ontario that's performing this trial right now. So it is very highly specialized.
Very exciting. Okay, my next question would be for Dr. Song. Dr. Song, maybe this question relates to cancer survivorship. So what is a breast cancer survivorship care plan, and how do you support your patients at this stage of their care?
So that's a pretty broad topic. So so right now within the Ottawa Hospital, through the works that's been done by many physicians and nurses and social workers, as well as reviewing clinical trials that looked at what would be the best model for ongoing survivorship care. The model that we're following right now for those patients finishing chemotherapy, doing well, stable on active endocrine treatment, what we have is to really involving their family physician in the care of the ongoing surveillance. Patient would have an individualized questionnaire done. So we're looking at specific individual needs and what kind of services they may require, as well as, looking at the different, whether it's general bone health or nutritional needs or psychosocial needs. Then we formulate this treatment plan or a summary of the ongoing plan for the family doctor. And then patient actually will have active follow-up by their family physician. I think one thing we try to reassure patient is that even when they're not actively being seen at the cancer center, the team here is still part of their multidisciplinary team. Really, they're one phone call away from us is that the family doctor can call us if there are questions, if the patient have any new issues. They can be brought back to the cancer center very quickly for reassessment. I think the benefit of this model is that when we're at breast cancer, we're so focused on cancer care. Sometimes I think other parts of the important prevention cares may or may not be happening when they're here at the cancer center, whereas a family physician really looking at a holistic approach. So when they are doing the regular surveillance, I think not only they're looking at checking breast cancer for potential surveillance, but they're also looking at blood pressures and cholesterols and looking at smoking cessation, looking at exercise and bone health. So I think overall, that has been proven to be an optimal model.
Wonderful. Thank you, Dr. Song. A number of questions coming in. The next one would be for Dr. Seeley. So Dr. Seeley, COVID has had many implications for many people everywhere. I understand that COVID has caused delays in breast cancer screening. Wondering if you could talk to us a little bit about what the Ottawa Hospital is doing to address the backlog.
Thank you. We've all been experiencing so much disruption with COVID, and you know, there are some benefits that we have, which is including these virtual conferences and more connections with my own colleagues, including Dr. Song and Dr. Cordero. But in terms of screening, we are seeing a huge impact, and it's achieved, a national, international attention. It's not unique to us in Canada, it's everywhere. So because we stopped screening last March for 4 months, because we didn't really know how to safely perform screening during the pandemic in the initial phases, which was the right thing to do, we stopped screening. And then we resumed it in somewhere in June, depending on the part of the province. Because of that, we have backlogs in the Ontario Breast Screening Program, which we have the best data collection for. In Ottawa, we have 24,000 women who haven't been screened. They just missed it altogether last year. But it's probably much higher than that, because we know that we have a lot of women who are being screened outside of the Ontario Breast Screening Program. All of our breast cancer survivors, all the women who are in their 40s, and all the women with implants aren't included in the Ontario Breast Screening Program. And we know that that is about 30% more than the Ontario Breast Screening Program. So it's probably a safe estimate that at least 40,000 women in Ottawa alone have not been screened last year. And we're also seeing hesitation of some women to come in for their screening because they're afraid of getting COVID. So we have implemented very, very safe guidelines for breast imaging. And I'm very happy to say that we have no documented infections. In fact, I would say that coming in for screening is probably one of the safest things you can do this right now, outside of going, to the beach with people. It's probably safer than that. We know in the province, the backlog is huge as well, 500,000. So how are we addressing it? I think the key is to communicate how safe it is, communicate the incredible need not to delay the screening. There was a study published based on modeling that showed that we would cause at least 600 deaths in Canada from women who weren't screened with just a delay of 6 months. So we know this is causing a delay in their diagnosis. And when I talked about advanced stage breast cancers, what we are actually seeing right now is more women presenting because they've delayed their screening with larger tumors that are more likely to have spread. And I find it heartbreaking to see this when we know it's so much preventable if we can detect it at an early age. So what we're doing is we're adding in extra shifts. We're trying to schedule appointments in the evenings and on weekends. We're hiring more staff to do this. But we do have an incredible backlog that we're going to have to get through. And what we're also seeing is that because we're adding in more screening, we have to do more biopsies. And our biopsies have gone up by 30% since COVID started. So we have now identified a tremendous gap in our capacity and a need for more ultrasound machines to do this. And, where we have relied on our donors in the past to get more equipment, I suspect we may need more help to fund extra equipment to do this. We also need the community to be involved to really encourage women to come in for their screening, because if I detect the cancer at an early stage, it means that Dr. Cordero has a less extensive surgery to do, and Dr. Song has less extensive treatment to deliver. So it really is important in reducing the morbidity and the breast cancer deaths from this early stage. Hope that answers.
Thank you, Dr. Seeley. You did, and it's a complex one to answer for sure. I notice we're already kind of getting short on time, so I'm going to ask just one last question here, and I'll ask the entire panel, and feel free to answer if you like. So, what is the survivorship of metastatic breast cancer, and has it improved over the last 10 years?
Looks like maybe I'll jump in.
Thank you, Dr. Song.
Yeah, so I have to say, I think the survivor or the survival of a patient with metastatic cancer has really drastically changed over the last decade with the introduction of HER2 targeted therapy, do blockade, as well as multiple small molecules targeting HER2 and really change the outcome of patient with HER2 positive breast cancer. And then in recent years, we now have CDK4/6 inhibitor for patient with hormone sensitive breast cancer. And that improvement of survival has doubled with the use of these agents. So I think the one that I think we still have a lot of work on is certainly the triple negative subgroup, but I think we're making small progresses. I would say every year we see some new agents with incremental gain in survival. Giving a number, I think, when patient asks me this question in clinic, it's actually a tough number to give, because I think I usually tell them, if you can be a bit patient with me, how you do on the first treatment we offer, it would be a great indicator of how long the patient may survive, right? So, for example, I can have 2 patients with hormone positive breast cancer, and one will be on first line for 8 years. That patient, I can guarantee, will survive past 10 years with all the things or tools that we have. Whereas I could have another patient who may be progressing after 8 months on that treatment, okay? So this is where I think research is focusing on, is that why are these 2 women different, or are these 2 patients different? Are we talking about personalized medicine? We're looking at different genomic profiling. So there are a lot of evaluations looking at circulating DNA. So we're looking at tumor markers, and while patient on treatment, in fact, we're bringing this clinical trial, we're actually going to be doing DNA testing or circulating DNA testing every couple months to see if patients are developing mutations, and we can introduce new treatment early. So I think the future is really, there's no patients alike, and we're going to be targeting the different patient with the type of cancer that they have, with special type of treatment plan. So I think it's not such a simple question. I would say for most of us, what we're telling patient is probably, let's see how you do. And but I think the future is quite hopeful.
Thank you, Dr. Song. I think the idea of personalized medicine and your response brings a lot of hope for patients. Surprisingly, we are at the end of our time. It has absolutely flown by. And so I want to thank all of our attendees for their questions and participation in this session. I wish that we had more time to go through all of the questions. We will try to contact you privately to help navigate answers for those that we weren't able to respond to. Again, I would encourage you to check out that resource tab on the platform main page, and to click on the resource page for this breakout session for a little bit further information. A huge thank you to Drs. Cordero, Seeley, and Song for sharing your expertise in this field. We're so very fortunate to have doctors and professionals of your caliber here in our community at the Rose Ages Breast Health Center. And we're just so grateful to you and to all of our donors for supporting this important work. So just a final note to our attendees, there's no need to head back into the main plenary session. Just stay tuned right here, and there'll be some closing remarks from Tim Kluk, which will begin momentarily. So thank you again. Thanks, everyone.
Thank you.
Welcome back, everyone. I hope you all enjoyed the breakout session you attended. Thank you again to all of our research experts who joined us this afternoon. Your insight is incredible. Before I let you go, I want to take this opportunity to thank the community for their generosity. Community support has a significant impact on getting many research projects off the ground and ultimately improving patient care. And we thank you for your commitment to the Ottawa Hospital and including us as one of your top philanthropic priorities. It's your generosity that helps create a healthier tomorrow for everyone in our city. If you'd like to learn more about the impact of donor support on our research or read some of our inspiring stories, please visit our website at ohfoundation.ca or follow the links under the resource tab. Thank you again for joining us today over your lunch hour, and have a great afternoon.